This
Thanks,
conference
Christina.
will now be recorded.
Okay, great. Thanks, Christina. Just want to make sure my mic is active and everyone can see my screen. Christina, can you just confirm?
Yes.
Okay, great. So we'll get started, and some people may trickle in and out as needed, but thanks to everyone for joining in this afternoon. Seems like lately we all have a lot more time on our hands, so that's one of the reasons myself and the other providers at our group are kind of doing some of these seminars, try to reach out to patients. As Christina mentioned, if you place questions in the chat box to everyone, since I'm presenting, I may not see them immediately, but Christina will help lead me to answer any questions that may come up. So I'm going to talk about, I know there was a question about COVID testing and safety and doing surgery. That's part of the topic today, so we'll get to that. And going to be focusing primarily on outpatient hip and knee replacement today. Certainly, I don't want to make this overly lengthy, but I want to allow time for questions and interaction as well. So we'll go ahead and get started. Sorry, I'm going to get back to my screen here. So this is just an outline of what I wanted to talk about today. So first, just kind of defining what does it actually mean to have an outpatient joint replacement, and some of the reasons and the who's and the what's and the how's in terms of how this has come about over the last decade or more. And then at the end of the conversation, tie that in with what's going on now as far as COVID-19, which obviously everyone's well aware of. And I think people are interested in knowing about, and it is a very important topic as well. So, just to start out, I wanted to clarify, it's confusing sometimes to people what exactly is meant when we say outpatient joint replacement. And most physicians and surgeons look at something that says the word outpatient, and I think many patients do as well, as meaning as having an operation and going home on the same day. So some of the things that we're very familiar with are things like hernia repairs, colonoscopy, some GYN procedures, as well as things such as an ACL reconstruction. And that's typically the definition most physicians and patients are most familiar with. And it's important to understand that in outpatient surgery, including a knee or hip reconstruction, can be done at a surgery center or a hospital. So what that means is a surgery center, or ASC, which stands for Ambulatory Surgery Center, means that it's a freestanding surgical center. And the hospital, obviously, we're all familiar with, where the person would have the surgery at the hospital, but still go home the same day from the hospital. The second way that outpatient joint replacement is viewed is more so through insurance companies, and this makes it very confusing. So about 2 years ago, about 2 years ago, Medicare and some of the other insurance companies, such as Aetna and a lot of the other big payers, changed knee replacement specifically, and now it's happening with hip replacement, to what's called outpatient surgery. What they were aiming at was not so much an effort to call or make a patient go home the same day, particularly if that wasn't an appropriate patient after they had their joint replacement, but rather it was a way to change what the payment was to the hospital. So the way things work in the US is hospitals get a payment for surgery, and that includes things like the implants, taking care of the patient, the operative time, anesthesia, and so forth. So it created quite a bit of confusion about 2 years ago when one of the largest insurers in the United States, which is Medicare, stated that total knee replacement can now be an outpatient procedure, and some of the big insurance companies followed suit. However, that did not mean that the patient who has Medicare has to go home the same day. In fact, the original intention was to allow the surgeon and the patient to decide who's appropriate, because not every patient is appropriate to have a joint replacement and go home several hours later. If you look at it from a financial perspective, hospitals get a certain amount of money with the assumption that the patient is staying 2 days, 3 days, which is historically, going back years, what people used to do. And that is not very common any longer, and it shouldn't be, as I'm going to outline. So what that actually means to the patient is that if you have Medicare or Aetna and you're having surgery and you get a letter that says that you are classified as an outpatient, unless you and your surgeon have discussed having the surgery and going home the same day, that does not mean that you will be discharged immediately. That's a discussion we have, and it's very important to have that discussion. What that means is they are considering the surgery outpatient because you'll be there less than 24 hours, and so they pay the hospital accordingly. And that's really what it actually means. It doesn't mean you have to go home right away. So that's an important distinction, but what I'm going to be focusing more on today is the background and the who's and what's of people who are having this operation and going home the same day, and how we got from what it used to be years ago to what it is now. So this slide's probably not titled correctly. I'm not going to give you a history of joint replacement per se, but what I wanted to kind of highlight here is where we were years ago and how things are these days. So back in the 60s and more so even the 70s, 80s, and even into the mid to late 90s, patients did not have their pre-op workup. As some of you may have had surgery before, you may be aware that typically what's done is all of your lab work, your medical clearances for surgery, getting new x-rays, seeing the doc or the PA before the surgery for paperwork. These are all done outside of the hospital. But back then, people were actually admitted to the hospital, and sometimes it would be as much as 2 or 3 days before, or even up to a week before surgery. And as crazy as it might sound to many of you, they would actually be in the hospital for those several days and do all of that pre-op preparation in the hospital. And so that would mean if you needed a lot of clearances, like a cardiology clearance, a medical clearance, all the blood work and the routine things, those would all be done after admission to the hospital. Typically after the joint replacement, the patient would stay in the hospital for several days. So, they would stay sometimes 5 days or even 7 days, and then eventually get discharged to a rehab facility. And I want to clarify, when physicians and nurses and hospitals discuss things such as rehab, rehab is not physical therapy. Physical therapy is the profession where we work to strengthen the patient's muscles and work on exercises. Rehab in this context is going to an inpatient rehab, or what's called a subacute rehab. Some people call them nursing homes. So some of the examples locally are places like Brandywine, Powerback, Care One, and their facilities owned by Virtua, Cooper, and various other institutions. So now as we move forward in the late 90s and 2000 to 2010 approximately, for the majority of the country, it was realized that every day you spend in a hospital setting increases your exposure to what we know can be more dangerous, for example, infections. And hospital-acquired infections are a huge problem and always have been. And so there has been a move in all surgical specialties, not just joint replacement, to getting people home more quickly and safely. So in the early 2000s, it was still felt that many people would benefit from going to an inpatient rehab. And so the common thinking was that your joint comes out better because you go to a rehab. But it was also recognized that getting patients out of the hospital quicker would help, not just in a cost savings, but also the exposure to infection and hospital disease. So by that point, all of the pre-op workup for surgery was done before the patient ever came to the hospital. You would come to the hospital the day of your surgery, get registered, checked in, have your surgery, and then within 2 or 3 days, go to a rehab center or home. So in the early 2000s, it was about a 50-50 spread. About 50% of patients, doesn't matter what their insurance was, ended up going to an inpatient rehab after the hospital stay, and about 50% of people were sent home. And over that decade, this first decade of the millennium, people started to realize, and studies started showing, that the people that went home, even from a hospital setting, encountered fewer complications. So they had fewer infections, fewer blood clots, and the process in terms of their knee and hip recovering specifically was as good or better. And in some ways, there were other things that played into this role as well. So I've listed here something called rapid recovery protocols. So this started to be adapted from other surgical fields where the thought process of keeping someone in bed. So when I was starting and even finishing residency, a lot of patients were put into splints after their knee replacement, not allowed to move, and actually kept still for a day or two on an IV morphine pain pump, and then they would get out of bed and start to walk, and this actually markedly slowed down getting better. And if any of you have had a joint replacement, you know that we actually preach to people to move every 15-20 minutes to get their leg moving, to walk every hour. So that was part of the advent or start of rapid recovery protocols. The other idea was that patients who have surgery and get home quickly within 24 to 48 hours, aside from having fewer complications, actually seem to recover a little quicker because they are moving. They're not laying in a bed with the idea in their mind that they're sick. So in addition to that, and I'm going to discuss this in another slide, where there were a lot of changes going on in the operating room and around the time of surgery that made a difference. So somewhere around 2005 to 2010, the idea that became very common around the country and has increased everywhere over the last 5 to 10 years is the idea that unless there is a medical complication or the patient physically isn't doing well enough, even if the patient's having surgery in a hospital, most people only need a very short stay and can go home preferably. And I discussed some of the reasons, but there are a small percentage of patients that still require an inpatient rehab stay. In our practice, that amounts to 10% or less of patients. And I typically describe the two reasons to patients as being, number one, if despite planning, you have no help, meaning no one that can stay with you for at least a couple of days or 3 days. Clearly, if you have help for a week, that's even better. But we don't do surgery on anyone, whether it's in the hospital or the surgery center, and expect them to be able to go home and be completely alone. The other factor that can lead to a patient potentially needing to go to inpatient rehab is if they don't do well enough. So when we start talking about this evolution about what used to be 20 years ago and what is now the case where patients go home the next day if they're not going home the same day, a lot has changed in order to allow that to happen, but we still have to look at the risk benefit on an individual basis. So, some of the questions that people ask, and it's very reasonable, are, well, why go home the same day? Isn't staying in the hospital better, or won't I feel better if I just wait a day or two? And so these are three of the main things that have come out of the last decade or even 15 years of studying patients who have a knee or hip reconstruction and are chosen properly to do so and are able to go home the same day. And to be clear, it's been an evolution. So the first outpatient joint replacements that I, my partners, or any physician across the country did was actually at a hospital setting. It was not in a surgery center and just, hey, let's see how it goes and try to get people home. It was actually meticulously thought out and proper patient selection. And what we found consistently and still find is that it does tend for most people to shorten the recovery. A way to think of this is that if your joint replacement recovers better by you moving and exercising and gradually increasing as you improve, then it actually makes some sense that if you go home, you have to move. So in the past, when you're in the hospital, the bathroom's 3 feet away, you can't get out of bed without a nurse or someone helping you. But when you're prepared properly and you go home, you get the ability to be in control of getting up and moving every hour and going to the bathroom, having your family visit, things that aren't always the same in the hospital, especially these days. Surveys have shown that patients that have outpatient joint replacement in general show higher satisfaction rates, and I think that also to a degree ties into the fact that they feel in control of their care. And then, as I mentioned earlier, what we found is that the risk of complications isn't any higher. I'll describe in another slide that complications actually are still common after any surgery, even having a gallbladder surgery. So many of you are aware that years ago, the vast majority of gallbladders were taken out in the hospital, big incision across the abdomen, and people would spend 3, 4, 5 days in the hospital, and it was a pretty miserable thing. Now they're done laparoscopically, 3 or 4 holes in an outpatient center. Doesn't mean that the surgery doesn't still hurt, doesn't mean that it takes time to recover from that, but it's expected people can go home safely. And my wife herself had her gallbladder out, and we had her home 3 hours later a few years ago. So things have changed quite a bit, and it turns out that when you are never in a hospital setting or you minimize the time in a hospital setting, you also get a decreased risk of infection because you're never near where bacteria are, or at least not for very long. So, when people ask me, if we talk about this evolution from where you spent a week or 10 days in the hospital before and after surgery, and now how is it possible that we can get people up, moving, and home? So, this is just a few of the items, and they're not necessarily in a particular order. So the introduction of less invasive or minimally invasive surgical techniques. So what this means, and different people have written articles and different doctors give topic talks on what is exactly minimally invasive. The best definition, I think, of minimally invasive is conducting or performing a proven procedure, something with a good track record, such as a knee replacement or a hip replacement, but doing it in such a way that damages as little of the tissues surrounding the parts that we're working on. So for example, I explain to people that when we replace someone's knee or their hip, we are fixing the bone problem. So if you have a severely arthritic joint that may need a joint replacement, we are replacing the damaged and worn parts. So when we put in a knee replacement or a hip replacement, everything around it has to be disturbed to a degree to put the implants in. But if you cut and damage less of the tissue surrounding the joint that's being fixed, people tend to have less pain and they tend to get up and get moving. Now, it's still a surgery, so we still expect people to have pain and need pain control, in the first week or two for sure, sometimes longer, sometimes shorter. And robotics plays into that to the degree that these are not robots doing the surgery on their own, but rather what's called robotic assisted joint replacement, which allows us to be more precise in placing the components. And as far as I've been concerned, having done minimally invasive surgery my entire career, has actually made it even less invasive because we can actually cut even less soft tissue and use the computer assistance in order to help guide where the bone is being shaved or taken to replace the damaged hip or knee. Multimodal pain management, this kind of plays into what I mentioned earlier, which is referred to in our field as rapid recovery protocols. So the idea is that in the past, the only thing that was used for pain control was pain pills. So, we're talking about opioids, and obviously we all know that opioids do have a place in pain management, but we have to be very respectful of the downsides, addiction, side effects, things that can really derail someone's progress and even permanently cause problems such as addiction. So going back at least 10 or even 15 years now, physicians doing joint replacement started developing other ways of managing pain. So changing the kind of anesthesia that was given, nerve blocks. So we do localized injections of Novocaines around the joint when we replace it, which at least can give some temporary relief of the pain. In our surgery center, our anesthesia team also gives localized blocks to the leg that also can help for even up to a full 8 to 12 hours to help early mobilization, which is getting up and getting moving, which is very important. People who lay around get blood clots more frequently or get pneumonia, and clots and pneumonia obviously can be very deadly. So managing the pain still involves taking pain medication as needed, but the thought process has changed quite a bit, where it used to be that we would tell people, take as much medicine as you need to keep your pain at a 2 or a 3 out of 10. That thought process really was not a good idea. The idea should be to understand going into an operation, there's supposed to be pain, but it should be manageable enough that you can still move and slowly recuperate. So aside from pain medications, unless the patient has a reason they're not allowed to take things like anti-inflammatories, that helps chemically reduce inflammation and helps with some of the pain and swelling after surgery. They're also not addictive, obviously, so that's another benefit. We advise people to definitely ice their leg after surgery because that can sometimes help a lot of people with the pain and the swelling. Movement and physical therapy, early mobilization is very important in that regard as well. I mentioned the injections and the anesthesia. And if we go down to the next point, the anesthesia and blood management has changed tremendously as well. So if you go back even 10 years before the advent of a couple of things that we now use, depending on the person's starting blood count, if you just assume the person did not have anemia and had a normal blood count, anywhere from 10 to 20% of people having a knee or hip replacement ended up getting at least 1 unit or pint of blood while in the hospital. So it wasn't necessarily just blood loss during surgery, but also after surgery. And anesthesia has impacted that. So patients that have what's called a regional anesthesia, where we try to avoid putting people on a general anesthesia, meaning with a tube and a ventilator, we instead opt to try to give them what's called a spinal anesthetic. So they're numb, so they can't feel anything during surgery, but they get twilight similar to what's given during a colonoscopy. So they don't really know most of what's going on during the surgery. That has markedly changed the amount of blood we lose during surgery. And in addition, also helps many people experience a little less in the way of side effects like nausea after surgery. Doesn't mean it gets rid of it for everyone, but it does shift the curve to decrease the number of people that suffer from that. Also with blood management, one of the things that has changed dramatically is a medication that all joint replacement patients get in our practice, but actually around the country and even the world. It's an agent given through the IV at the time of surgery that markedly reduces the amount of bleeding. And so what we find now is that compared to in the past, when even someone was very conservative, I would try to avoid transfusing patients unless I absolutely had to. And so I still had 10% of people I might have to transfuse, where now in the last 2 or even 3,000 people I've done a joint replacement on, we've had to transfuse 1 or maybe 2 people. So with all of that, with the medications we can use and the anesthetic agents, we don't worry as much about needing transfusions, which also helps keep people out of the hospital. Because as everyone usually knows, you can't transfuse people at home or in a surgery center. It's inappropriate. That's also helped us not to have to worry about getting blood work. We used to routinely get blood work on patients every day they were in the hospital. And now we actually pick and choose. The data shows that there is really no great reason to get blood work on a patient after surgery unless you're looking for something specific. So perhaps if the person is anemic pre-op, or if their potassium was low before surgery because they take a water pill. So these are things we decide on a case-by-case basis. Attention to early problems, what I meant by that bullet point is that some of the most common things that can hinder people getting up and getting moving and going home, and this doesn't just mean at the hospital and if you stay overnight or if you have surgery and you're home the same day, it can be at either setting. So we're talking about very common side effects that tend to go away, such as nausea, low blood pressure, dizziness, things that can make it difficult to get moving and get home. And what's been discovered over the years is it isn't just pain medicine or anesthesia that impacts patients in that way, although those are definitely factors and they tend to wear off within 12 to 24 hours. A couple of the other things that make a big difference are nutrition and fluids. So for example, everyone that's had surgery knows that we tell people to stop, classically eating and drinking after midnight before surgery. That's changed where most of the time what we try to do is tell people not to eat any solid food or any soft foods like applesauce after midnight before the surgery, but that you can still take clear liquids such as Gatorade or Powerade, but something that doesn't have anything thick in it. Water's okay, black coffee for even up to 4 hours before surgery. This allows people to have less dehydration, and dehydration after surgery is a main cause of low blood pressure and associated dizziness and nausea. So we also have eliminated using Foley catheters for all the patients. So we don't put catheters in people's bladders when we do the operation, but as soon as they get to the recovery room, we give them extra IV fluid and want them to start drinking fluids to try to help with those early problems. And that makes a big difference in decreasing the chances of ending up with nausea and dizziness that keep you from getting home. And I think lastly in this list is pre-op preparation. So what that means is that when we have patients that are going home the same day, we prepare them differently. When someone has surgery and stays a day or two in the hospital because they're having issues or they live alone or they're very debilitated before surgery, physical therapy works with the patient. We may be checking labs, but they learn to do what they need to do after surgery in the hospital setting. So when someone is going to go home the same day, I don't want them to learn, how do I use a walker? How am I going to transition to a cane? What do I do as far as stairs? How am I going to get my pants on? I don't want that patient to learn that after they've had anesthesia and a painkiller. That's really not the best time to teach them that. The best time to teach them that is before surgery. So we have our patients work with a physical therapist. Sometimes it's in the office for 5 or 10 minutes. Sometimes we actually send the patient to the physical therapist and have them show them how to negotiate using a walker and a cane. How will they do stairs when they get home? Whether they only have 2 or 3 to get in or they've got a flight to get up and down to bed at night. So that preparation is part of what makes a big difference, so that when the patient is coming in for the surgery, yes, it's a new experience. They don't know everything, but they've been taught most of what they need to know, so they feel pretty confident in what they're going to have to do. So the picture on the lower right is one of the patients from our surgery center, and it's actually a video that's on YouTube, but this is her walking about 2 hours after her knee replacement. So you can see the bandage on her right knee, up with the walker. And if any of you on the call today have had surgery, you'll recognize that hallway because that's a pre-op area and one of the areas that our patients walk. And we even have a place where they practice the stairs if they want to before they go home. This slide, not to get off topic, this is just to clarify. A lot of people say, well, what does robotic mean? So on the left is, these are 3 separate units. We only have one of them in the OR when we do robotic hip and knee replacement. This on the right, you see a screen where there are computer screens, and I'll use the cursor, but up here, there's this infrared eye. And so when we do robotic surgery or robotic assisted surgery, I'm trying not to be gross or overly detailed, but the tools that we use to help prepare the bone for the implants are attached to this robotic arm that has a base that is manned by a man or woman, by a technician that works with us called an MPS, as product specialist. And with a CAT scan we get preoperatively, All of that data is fed into a computer to make a three-dimensional rendering of the patient's hip or knee, so that when we prepare the bone for the implants, we can be more precise, because when we use the robotic arm, it only allows us to perform the bone resection that we've planned using the CAT scan. So again, not to get off topic, but a lot of people get confused and assume that we start the surgery and go get coffee while the robot does the surgery, and nothing could be actually further from the truth. The other thing that's also very different, most robotic surgeries like lap choles, appendectomies, prostatectomies that you hear about, gyne surgeries, those are typically done with a very commonly used robotic tool called the Da Vinci. That's the main company that's the most popular. That's actually very different, where there's an entire robotic machine. Essentially, it's the size of a small room, and that is at the patient while the surgeon is sitting 10 or 15 feet away working on the patient. In joint replacement, we are actually holding the end of this arm at the patient's knee or hip, so it is directly controlled by the physician. So we're not away from the patient at all. So, you know, who actually might be a good candidate for outpatient surgery? And I do point out, or I'll preface this by saying, these are just some of the things I look for when I discuss it with patients, but it is a discussion because there are other factors that may mitigate or change who might be a good candidate for this. And not everyone, as I said, is appropriate for this. So currently, anywhere from 20 to 25% of my patients have their knee or hip done and go home the same day. So obviously that means upwards of 70 or even 80% of people don't. The rest of those patients that have it at the hospital typically stay overnight and go home the next day. But as I mentioned earlier, that's based on how they're doing and any medical issues that may come up. So the first thing I look for is someone that's in good health. Now, want to clarify, that doesn't mean they don't have any medical problems. What that means is they don't have more serious problems that should be monitored overnight. So for example, someone who's had a heart attack before, or they've had cardiac stents placed, perhaps they have pretty significant kidney disease, so maybe they're not on dialysis, but they are not allowed to take anti-inflammatories, and they have pretty severe issues with this. Those patients aren't really appropriate for a surgery center or to be home 6 or 8 or 10 hours later. Now, when I say healthy, what we're talking about are patients who have controlled medical problems. So if we have a patient who's diabetic, takes blood pressure medicine and cholesterol medication or a thyroid pill, but all of these things are under control and in good shape, and their family doctor has not found any red flags or warning signs, that patient is considered healthy and stable for a surgery and is a potential candidate. Having good support at home. So, you know, many patients, for one reason or another, won't have support at all. So for example, they may be single, you know, or widowed, or they say, yeah, I live alone now. Maybe they don't have a son or a daughter, or a friend, a neighbor, sister, brother. And so they really don't have the right support to be home. Those people should have their surgery at the hospital. We still encourage them in the time that they're waiting for surgery to work diligently on trying to find support to go home, even if it means they stay a night in the hospital, because as I mentioned earlier, the complication rate is higher across the board for patients that go to an inpatient rehab. It actually doubles your chances of ending up back in the hospital within 30 days. So unless you're not doing well or can't find anyone to help, going home is a good idea anyway. But if you're going to try to go home the same day, the good support and the not being debilitated play into each other. So if I have a patient who otherwise is in great shape, but they have gotten to the point where they rely on a walker or a cane to ambulate, you know, to get around, that person's going to need a little extra time to be strong enough to be safe to be home. Their balance may not be as good as it used to be, so that may not be the right person to go home right away. And then the last two, I think, also tie together as well. The patient has to be motivated. You know, they have to be motivated to say, yep, whatever it takes, I'm going to do it. I got to get better. And as I mentioned earlier, we prepare them differently because we want them to take their care into their hands. Patients of mine have heard me say, and I say it to all people in preparation for surgery, how the patient does after the operation is actually only probably about 50% dependent on the surgeon. And that doesn't mean that what we do doesn't matter. It is very important. But as I mentioned earlier, if we're fixing the bone problem and everything else is reliant on the patient's condition and their dedication to doing the exercising, walking, and adhering to the regimen over the course of the months that they get better, then it really is an equal responsibility, and both people are equally important. So preparing the patient for that and then having the patient follow through is very, very important in how the person turns out, or rather how their hip or knee turns out. So another question that comes up is it safe? And I won't belabor it. I love the cartoon on the right. That's for those of you that are Far Side fans. Gary Larson, he was one of my favorite comics growing up, and still love his stuff. But and we don't use any zebra parts. So one of the things I point out is that no matter where you have your surgery, and I don't just mean outpatient or in a hospital or a surgery center, but no matter where you have surgery in the world or the country, who your doctor is or who your patient is, there are always risks with surgery. And we try to explain that to patients in detail, because even if someone doesn't necessarily want to hear all the bad and the good and the ugly, you do need to know that. So the risks that go with surgery, things like infections or a fracture occurring during surgery, blood clots, those don't disappear because you have the surgery in one place or another. But one or two things that I did mention earlier, for example, readmission rates. So people having surgery and going home the same day do not get readmitted to the hospital with more complications or for other reasons at any higher rate. In fact, there are some studies that show that they have a slightly lower rate. So for example, blood clots, as I mentioned, and infection, patients actually tend to get readmitted at a lower rate if they have their surgery and are home the same day, particularly if it was in a non-hospital setting, meaning in a surgery center or an ASC. And then again, what is very important is proper patient selection. So does it make sense to take a patient who's 50 or 60 years old or even 80 years old? I don't necessarily pay only attention to the age because I don't think that's appropriate. I have patients that are in their mid to late 70s and they're in better shape than I am. And it's not because I'm in terrible shape, but they're in great shape. But having the patient who is markedly debilitated, severe medical conditions, that's not the right person to just get up and go and see you later, go home. So it is safe, but it's an appropriately selected patients. And then to tie this together in the last couple of slides before we start questions, and discussion. So obviously everybody's very, very well aware, acutely aware of the COVID-19 pandemic that we're in. And just as a brief timeline, the first cases were reported towards the end of last year. So that's where the name COVID-19 comes from. You may all be aware of that. It stands for coronavirus, and it was particularly from 2019. And it's a new strain. So a lot of people don't realize coronavirus is a common cold virus. So most of us have probably had a coronavirus upper respiratory cold before and never knew anything about it, because there are many, many viruses that cause the common cold. What's different about this, of course, is that this is a mutation. So many of us remember the SARS epidemic that was really limited to part of the eastern part of the world. And that died out. It killed a lot of people, but it died out very quickly and has not resurfaced. COVID-19 is essentially SARS-2. That just means it's a severe respiratory syndrome, but it is a mutation. And so as many people are aware, I looked online at Johns Hopkins database, and as of yesterday, and it hasn't changed much today, well over 1 million US cases. And I'm not going to get overly political and discuss the testing and all the other things, but we've got more than 80,000 people that have suffered and died from this disease, and we're still working through it. So, I do think this does have implications in the sense that all infections are bad. So when we do joint replacement, COVID-19 is a virus. It's not going to cause an infection in your joint replacement. However, if you have surgery, you are essentially in a debilitated state initially, right? So one way to think of it is surgery is a shock to the body. So you don't want to be exposed to coronavirus or COVID. None of us do. So that's why we're wearing masks and we're staying home more, and we're trying to avoid getting together with our family, our grandparents, our grandchildren, and so forth. So I think in a way that actually highlights the importance, because the less time you spend in an area where you can be exposed to this. So we're not going to grocery stores and hanging out with our friends right now. Same thing goes for having an operation. If you're going to have an operation, whether you're having it at the hospital or the surgery center, you only want to spend the appropriate amount of time there in order to minimize your exposure to all infections. But currently, I think this ties into the coronavirus. And the dangers of infection, I think people really, really get in a different way now than ever before. The last time, in the news, they talk about the last time we had something like this that was so contagious was Spanish flu, and we're talking World War I era, a long time ago, and certainly most of us weren't around then. So I think it does highlight the reasons why people should avoid hospitals unless they really have to be there. So in regards to hip and knee replacement, a lot of times, I've spoken to a lot of my patients. I've had to reschedule a lot of people, and we're still waiting on dates, and it's been a very difficult thing. Hip and knee replacement are considered elective surgeries. So To clarify, elective doesn't mean it doesn't need to be done. Many of you may need your hip or knee done. You may have already had it done, or you've had one done. And those of you that are in pain and getting injections or considering surgery know it doesn't mean it doesn't have to be done. It means that it is something done when the patient's in good shape to have it done, and it's appropriate to do it. And so elective doesn't mean you don't need it. It means that it's done by choice, planned, timed out. So when this coronavirus pandemic started taking foothold, there were two goals. One was to keep hospitals free of people that didn't need to be there, to save equipment, personal protective equipment, gowns, masks, ventilators, for what was expected to be an onslaught of patients getting ill. And from the get-go, the thought process was, if we put these measures into place, then we hopefully will not have thousands and thousands of people getting sick. And it is working, but it stinks. You know, we all know that from a lot of different levels. That being said, hip and knee replacement, while it can be a life-transforming type of operation, is considered elective. It's not considered an emergency, except in very rare instances. So by mid-March, the vast majority of surgeons, including myself and the hospital systems around the country, stopped performing hip and knee replacements unless it was an emergency. So for example, if a patient who needed a hip replacement ended up falling and breaking their hip, you know, the recovery is terrible in that regard because now it's a trauma, but that patient needs their hip replaced. So that is no longer an elective surgery. But now, as we're looking to start back up, and you know, I'm not an authority on the timeline, but as you're already hearing, these surgeries are starting back up around the country, depending on the degree of infections and what's going on in the hospital system. So it can't be a blanket start and stop. So I have colleagues who are operating in Ohio, Massachusetts, out west in Texas, but they are starting at a different pace. And so the thought process is that we are hopefully going to be starting to get up and going again by June 1, but it's going to be with different protocols. So for example, we know at our surgery center, and I'm not making all the final decisions on that. We have a board that's working on that where our surgeons are involved. But for example, things like checking temperatures on all patients, testing patients. I do know Virtua Hospital, which is where we do our inpatient surgeries, and for joint replacement at Virtua Voorhees, they've already announced that the protocol is going to be that patients will get their pre-op blood testing as they normally would a couple of weeks before surgery, but then 48 to 72 hours before their surgery date, they're going to be asked to go back and get a COVID-19 test. So we'll have a negative result before they come to the hospital. And, you know, it's screening the patients for their sake, but also in my mind, telling them once they've had that test, stay home, you know, don't expose yourself and go out and potentially pick it up and then have the surgery. At the hospital and the surgery center, there's also the advantage of less traffic. So for example, at the surgery center, as is probably obvious, you come in through one door, you leave through another, and really the only people you come into contact with is a small team of people that are going to take care of you, the nurse, pre-op, anesthesia, the surgeon and his PA, and then, you know, your family to get you up and home. At the hospital, at Virtua Voorhees, we are fortunate in one way in that the Musculoskeletal Center there, or the Joint Replacement Institute, actually is a building that's attached to the hospital, but it has a completely separate entrance as an outpatient building where we have an office there. There are other offices like CHOP. So that at least means that if you're coming in for surgery at the hospital, you're not going through the hospital, where obviously the COVID patients and any other patient is as an inpatient. The other thing is the unit that patients stay on after surgery, if they're staying overnight, is a orthopedic unit. It's a musculoskeletal unit. There have been no COVID patients there even since this began, and there won't be any there after. And so that we feel does give us a leg up in the sense, no pun intended, where we have a cleaner unit. And the operating rooms have also been separated where there's only one OR that is used for emergency cases, such as a broken hip or a broken leg, where the patient is tested positive, and everyone is using precautions such as the N95 masks, minimizing exposure, separating patients. Downside is that we're not allowing visitors in the hospital, so that's a tough thing, you know, where if you have a surgery and you have to be in the hospital, you can't have family visit. It's for their safety, the patient's safety, but also the staff, and avoiding transmission of the disease. So there's going to be a lot of changes in terms of how we do things. And I think it's safe to say that we don't, and when I say we, I don't mean just physicians or hospitals, but the public, you know, the government, the governors, you know, the White House. No one exactly knows what's going to happen, no matter what anyone says. We have to have what's called surveillance, which is keeping track of not just COVID infections, but other complications as we slowly start to restart surgery. So even when we restart in June, we know that we're not going to jump right back in and flip the switch. We're not just going to be bringing in patients the way we did before. It is going to be very different in order to keep patients separate. Everyone has to wear masks and continue some of the precautions we're doing now until we know they're safely home again. And so again, I do think this underscores or highlights the fact that whether you have your surgery and you have to stay in the hospital overnight, or you're having your surgery and you're going home, home is the safest place to be right now. And I think people really understand that because of this pandemic. And just a couple last quick blurbs. Many of you may be familiar with our group, but we encompass all types of joint reconstruction, but also preservation and people that don't need joint replacement but need something else done. There's 5 of us that do hip and knee replacement specifically. And you know, among the fact that we have lower complication rates, the big one that patients frequently ask about is infection rates. Excuse me. And our rates are much, much lower than the national average. And we are all over the place. I don't go to every office, but we cover every aspect of orthopedics, not just surgery. You know, I tell people the majority of people I see don't need surgery. And if they do, it's often not right away, and it is up to them to decide when. And we do have offices going as far north as Bordentown, all the way down to Vineland. And then this is actually one thing that hasn't been updated actually. We do have a walk-in orthopedic clinic, but currently we're only running the Medford location Monday to Saturday. So if someone has a walk-in problem, severe pain, or they fell and they think they broke something, it is a way to get an x-ray and see someone who does orthopedics without going to the ER 6 days a week. And with that, I'm going to end and let Christina kind of take back over as moderator, but love to open it up to questions. And I think, Christina, you'll be helping with this, correct?
Yes, Dr. Jane, thank you for your presentation. It was very informative. I think you covered the one question that we had prior to the start of your presentation. Did anybody have any other questions? If you didn't want to type it, I'm okay with you unmuting your microphone as long as not everybody's doing it at the same time.
I have a question. Can you hear me?
Yep, we can hear you.
I see Arlene Burke.
Yes, that's correct. Hospital setting versus the surgery center. Do you think one is safer than the other?
Yeah, I think so. I think if you look at it from the aspect, and there's actually literature supporting prior to this coronavirus, so I kind of like to make sure people understand there's the thought processes we had before this started, and then there's a thought process we have now. And I think it's helpful to know that. So the data does suggest that people that have surgery in a surgery center, just overall the appropriate patient, has a knee or hip replacement in a surgery center where they're never exposed to the hospital environment, they actually do have, as far as infection for sure, and I think if you add to a coronavirus even more so, less exposure risk because no one stays overnight. It's literally in, and we have some patients that are home 3.5 hours later. Sometimes they have to hang around a bit to make sure they can urinate, or they're a little nauseous and we want to make sure that's under better control, and they stay 8 hours. But even those patients have a slightly lower chance of infection than patients who come to the hospital, have the surgery, and go home 6 or 8 hours later, compared to the patients that stay overnight. And again, that is also assuming all other things are equal, right? So that we know the patient's appropriate, they have the right support, they're not so debilitated that we don't think they'll safely be able to go home. So I hope that answered that question.
Okay, yeah, thank you.
Dr. Jane, I had a question come in. What will be expected of us before we are allowed to leave the hospital if we are outpatient? What will you be looking for in our physical capabilities?
Sure, I actually just looked that up in the chat there. So actually the criteria we use are fairly similar at the surgery center and the hospital, but it's a great question because one of the differences is in the surgery center, it's our nurses who are trained to make sure the patient can do the same things that a physical therapist does with the patient after the surgery. So typically what we want the patient to do before they leave is walk at least 100 feet. Most of them walk 200 or 300. Some of them we even have them walk down the hall to where there's a staircase. But the things that we expect them to do or want them to do, particularly at the hospital, is to be able to walk down the hall. We want to make sure they can do stairs. So if they've got a few steps to get in, obviously we want to just show them the correct way to do it. And then in addition, we try to make sure people can urinate before they go home. That's true no matter where someone has surgery, that their blood pressure appears stable, that they're not having major problems with dizziness and nausea, things that we usually can correct by giving more IV fluids and keeping them a little longer. The only difference in the surgery center, as I mentioned, is the nurses there will work with patients to get them up. I've been told by the nurses, and I've seen, we do have a what's called a car simulator, as well as a set of staircase, a few steps that we can make people go up and down a couple of times. What I've learned from the nurses in the recovery room at our surgery center is majority of the patients actually don't want to do it. As long as they feel like they're doing okay, they'd actually rather just go home. But at the hospital, what we try to make sure is that medically everything looks fine. So if there's any medical reason we're doing an outpatient surgery at the hospital to be sure the patient's fine before they leave, we want to make sure that's okay. And then the other aspect is making sure the therapist feels, yeah, the person's walking well, they're stable on their feet, and we taught them how to do stairs. So I hope that makes sense.
And a follow-up question to that.
Yeah.
Will we be going to physical therapy, or will be doing exercises at home?
Great. So, yep, great question. So in general, we always encourage people to do physical therapy. And to your point, there's two ways to go about it after the surgery. So there's what's called home therapy, where many insurances will cover a physical therapist coming to the house 3 times a week or twice a week to work with you at home. We recommend in general, when people are able to go home and they have someone that can take them to therapy, to actually go right to an outpatient therapist. They tend to push you a little harder, and all things being equal, you know, I tell people you'll still have pain and swelling and have to manage those things, but people tend to recover a little more quickly when they get pushed by an outpatient therapist because they do work you a little harder. Now, that's what we've told people in the past. Now, if you look at the coronavirus pandemic, we are finding that we are doing less therapy, and a lot of patients are wanting to do less therapy and doing more of it on their own at home. There is a difference between hip and knee replacement, and I think that's, again, a generalization, but in general, hip patients, when they sit, they're bending their hip. A knee patient has to work on bending their knee. So a lot of the patients that we do hip replacement on, even before the pandemic, could do 2 weeks of physical therapy. If they were already off their walker or even off their cane already or close to it, some of them don't need any more therapy formally. They can do their exercise on their own, walk, and then we recheck them by 6 weeks and see if they're doing okay or not. If they're not, we can send them for therapy. Some patients go for another couple of weeks. With knee replacement, many of the patients do need 4 to 6 weeks of a therapist also pushing them and stretching. But what we're finding is, even with the pandemic, the patients that we operated on that then lost the ability to go to therapy, the vast majority of them are still doing just fine. They work very hard on their own. And as I mentioned earlier, that plays into the fact that it really is critically dependent on how hard the patient is working on moving their knee, range of motion, doing the strength exercises regularly. So I always now at this point tell people, if we need to do therapy, let's start with 2 weeks and then progress from there and add and subtract, you know, as needed. One of the greatest tools that someone can have at home that helps them after the knee, but also after a hip replacement, is an exercise bicycle. I strongly encourage people that can do it before surgery to do it, because it is low impact. It can help keep your muscles strong. And you don't have to spend a lot of money and get a really expensive bike, but you have to be willing to use it. And of course, have the space, you know, and the ability to put it somewhere where you want to use it and will use it. After surgery for both hip and knee replacement, a lot of patients find that it helps loosen their joint up. And it works just as well as being able to go to the gym or do physical therapy with someone. Excuse me, again, it does also relate to the fact that the exercises you get taught by the therapist, as well as things you like to do for exercise, are critical in gaining that recovery over the course of the months after the surgery. So I hope I was pretty thorough in answering that. Hopefully I got that through.
Were there any other questions? Somebody you can unmute your mic.
Okay. I don't have any questions.
Great.
Thank you very much.
Hi, you're welcome. Thanks for joining today. I'll stay on for another minute in case anyone has any other questions, but I'm not offended if you got to leave. But I hope you all found this helpful or informative for whatever you were looking for.
Okay, thanks so much. Okay, bye.
Thank you.
Just push the
Well, I just want to thank everybody for joining us this afternoon, and just remind you that we did record this session, and it should be on our website by the end of the week, so you can go back and reference it. One other question did come in. When will we know if our scheduled surgery will still happen?
Yeah, good question. So we asked the same question, right? So one of the things that has been really difficult is the rescheduling of people, because there are some people that really need their surgery done. They're in a lot of pain and don't want to wait as long as it's safe. I've had many of my own patients say, you know, with everything going on, I think I'm just going to push this off to the end of the year or wait till things settle down, which is very reasonable. And unfortunately, it is a touch and go thing, because currently, for example, with the starting date that we think we have of June 1, part of that is going to depend on, over the next week or even 2 weeks, continuing to see this so-called flattening of the curve, where we're still seeing new cases of coronavirus, but it's not continuing to increase. We're not seeing increases in, unfortunately, deaths and infections. So I think that's going to be very important. What can't we predict? You know, and those of you that watch the news have heard his name, you know, Dr. Fauci, Dr. Birx, and many other professionals across the country that have nothing to do with CDC, is also watching very carefully what happens when we start and being careful. So unfortunately, at this moment, we do think June 1 is going to be a good date to start back up. But it's a good point, because there may come a change, and many of my patients that have had to be rescheduled, many of them have already had a second reschedule when we thought it was going to be May, and it turned out it was not going to be May. So what I'm telling all patients is that as soon as we know that there may be a change, the patient's going to know, because you're all waiting, you know, when someone's scheduled for surgery with me. So my administrative assistant has done her best to keep people abreast. I always invite people to call back and let us know if they have questions. But part of the difficulty is, you know, as you probably heard people say, the virus is controlling where we're going with this. We're only kind of along for the ride and trying to be safe so we can get back to life, even if it's a new normal. So if there are changes, you should be contacted by my office, by my assistant.
Thank you, Dr. Jane. If there's no other questions, then I guess we can go ahead and end this. Again, thank you, Dr. Jane, for your time this afternoon, and I wanted to thank everybody for joining us again.
Thanks again, everybody. Be safe.
Okay, so I guess that's